Yeah, thank you. So look, I think it's an area that we really need more data. I think we're only getting the start of this with, with Alina and Elevate and the very small neoadjuvant studies. So we need more data. But I think my main observations are that ALK is different to EGFR. The fusion-driven tumors are different to the mutations. We see a higher pathological complete response rate with ALK than EGFR. And to me, this tells me that the drugs are killing more cells in the fusion context than in the mutation context. And to me, although we don't know whether pathological CR in a fusion tumor is the same as a pathological CR with immunotherapy, I think this is a very positive signal. I think in terms of the approach, I think one big strength is we learn a lot about the tumor based on its response to treatment. And I think, as Dr. Liang very nicely said in her talk, there is an opportunity to personalize subsequent therapy. To me, I think one way of doing it is, although we haven't seen so much that the variant 1 versus variant 3 seems to make a difference. Although, we used to think that variant 3 is maybe more aggressive than variant 1, but that doesn't seem to be the case with these highly effective treatments. But to me, in a patient who has had less than a complete response, who potentially has a p53 mutation or some other co-mutation, I would consider giving them adjuvant chemotherapy and then potentially having maintenance treatment with, for example, lorlatinib if they had alectinib beforehand. In other words, intensification of treatment. And I think we can possibly also use, as the technology gets better to detect fusions in plasma, use ctDNA and MRD detection to guide that decision. So I think this is a really important area. And I think in China, the work that's being done, for example, with the Lauren study, I think will be really important to help us work out how to proceed with this.